our SYMPO. On behalf of the Philippine Heart Association Board of Directors and First, let me formally welcome every one of you to the symposium. And we're very fortunate that we have a speaker coming from all the way from Europe to speak on how to get hypertherapy at goal combination therapy. He's currently a full professor at the university, head of the Department of Internal Medicine of the Clinical Hospital Valencia, for the last 8 years, Scientific Direct Research Institute in Cliva. He published reports and studies, lectures in many meetings, and he's president of the European Society of Hypertension from 2011 to 2013. My dear colleague, to welcome Professor Josep Redon.
Good morning, ladies and gentlemen. I would like to express gratitude to the organizers for the opportunity to be here today and for the kind from the chairman. Well, that I am going to is how to get hypertension therapy at goal. One of the main we have of hypertension. And after my disclosures, that's the slides, please. It's in front. Well, that are my disclosures, and as I told you that in the following minute, I am going with you this symposium, taking in account 4 different types. First is what the magnitude and the problem. Of course, that as you will see, many of hypertension, the real situation is that rate of control are very low. After I will do how to get blood pressure control and the role of combination in this. Finally, I will how and when to use it following recommendations, more relevant guidelines, the scientific is over the world. Concerning it, this is one slide that I think all of you know, but this is the attention ranks as a leading factor for worldwide mortality. And even that is important. It is more important the fact that from 1990 to 2010, the problem has not been reduced, if not has been increased. As you will see that among the most relevant cardiovascular risk factors, hypertension is the only that increases, and increases in more than 2 million. Then this means that we are not doing the best to control blood pressure. And even that we know that reducing blood pressure, it's relevant in terms to reduce morbidity and mortality. This is a meta-analysis published many years ago in which the impact of reducing blood pressure in systodiastolic and isolated systolic hypertension, the comparative effect against placebo, achieve a very relevant reduction in fetal and non-fatal events and also in mortality, mainly cardiovascular mortality. But after these studies that were performed against placebo, and after the end of the 80s, practically all the studies that treating hypertension were comparative studies in between different kinds of treatments. And you will see here what is the impact of the differences in blood pressure. The higher the differences in systolic blood pressure, the higher the reduction in cardiovascular risk in a very, very large number of different kinds of trials. And this reduction achieved for the differences in blood pressure in between the arms is related with our reduction in the incidence of stroke, cardiovascular disease, coronary heart disease, cardiovascular mortality, and also total mortality. But the reason for that we still as the ranking the first, as the cardiovascular, as the mortality over the world, is mainly related with this. If you look at over the world, in different countries, in different continents, you will see that among subjects that are treated for hypertension, no more than the percent that you will see here is still under control. And then data, I have data here around of Europe. This data for Spain is old, but we have improved a lot. But as you will see here in Philippines, the data that I get from here is that 27% of the patients diagnosed and treated for hypertension is still uncontrolled. But if we have this, what are the barriers to control? The barriers is a mix. It's not just only one thing. There is a combination of things. Combination that include the patient adherence to treatment, the physician inertia, and also, it is relevant, the healthcare structure and organizations. But in the frame of all of this, we need to consider that there are many of the mechanisms for blood pressure elevations that are acting against the possibility that we can get success in a more higher rate of control. And then I am going to analyze a little bit each of these. If we go to the patient adherence, this is, for example, what happened. If you get these are data coming from the different even clinical trials. But if this has been replicated in electronic health recordings of populations with hundreds of thousands of subjects, what is the reality is that after starting one antihypertensive treatment, it's clear that at the end of the year, more or less half of the patients are not still in treatment. And not only this, if not some of them, even that start taking the treatment and still in the treatment, are not following the recommendations for the correct dosing of the drugs. In other words, it's like they are not really taking the medication. And what are the reasons for that? The reasons for that are several, but in this, for example, it is very demonstrative. This is coming data from electronic health recordings from practically 500,000 of people. What are the people that is less compliant with treatment? Women, young people, those that are taking antidepressant drugs, and those that have comorbidity such as COPD, rheumatological disease, neoplastic disease, or dementia. But together with this, it's also important the kind of drugs. As you will see here in the same survey, that the diuretic subjects are those that have less persistence in treatment, when you will see that the blockade of renin-angiotensin system, A or B, are the best that in terms to maintain the treatment. But it's relevant the kind of drug, but it's also relevant the number of drugs. This is one study in which practically analyzed a very large number of subjects that are taking medication for different things. According to the number of medications that the patients are taking, that the highest the number of medications, the lowest the compliance when you add one drug to reduce blood pressure or to use lipid-lowering agents. This lack of adherence is relevant. For example, you will see in this study how those subjects that have the more compliance, that take more than 80% of the scheduled dosage, are able to improve the control, the blood pressure control, as compared to those with less adherence to the medication. And together with this, it is not only important the rate of control, it's the consequences of the rate of control. In this study, you will see that according to the compliance, what is the risk for hospitalization in patients with high taking antihypertensive medication. And if you look at the risk in terms to have one acute myocardial infarction or stroke, in those that are not persistent with medication, have a 15% more increment of risk in 2 years, or 28% more risk to develop a stroke in 2 years. In other words, we need to consider that lack of adherence, it is an important, let me say, risk factors at the time to have a risk to develop cardiovascular disease. And then you will see also that, as I showed you before, the best control, those that the low adherence and the compliance in within 6 months after diagnosis have much more risk as compared to those that are compliant with medication and have a very high levels of compliance that are taking more than 80% of the scheduled doses. But it is important too, more important in a short-term evolution concerning the risk on subjects with very high risk. If you remember, the on-target study was one study that enrolled patients with high-risk cardiovascular, 76% with coronary artery disease at the beginning. And as you will see, what is the impact of those that during the trial that take out from the medication? You will see that for the main endpoint, cardiovascular death, and even that a little bit coronary congestive heart failure, that have a sort of increment of risk, mainly for cardiovascular death and for the main endpoint. And this was even more important in subjects that during the trial have one event, and then the patients following treatment or leave the medication. Then you will see the very important gap, mainly in these subjects for sure. The highest the patient, the risk, the baseline risk, the highest the importance of adherence in terms to achieve success to reduce morbidity and mortality. What about physicians? What about our behavior in front of the patients every day? Then there are several studies that if you ask to the awareness of risk of the doctors, and you ask to one doctor, how many of your patients are controlled, have blood pressure controlled in your clinic? Then in different countries, in US and Europe, you will see how the response is practically around 50%. But when you look at the same, the rate of control countries, practically you will see the. Then it's clear is that many times, how we are seeing just only individual patients, we are many not aware of the real risk, and we don't persuade the patients to take medication or even add medication if necessary. And then we have several excuses. This is one study to patients that don't use medication what's necessary in a patient, and what are those that they say? I think the patients are not following lifestyle. And then I think that the patients are not taking medication all completely. They will say, hey, do that. I think that, well, I am measuring blood, it's a white coat effect. And then I say, okay, well, it's necessary to increase other reasons. In other words, what happens every day in the clinic is sometimes put some excuses in order not to increment the dose of the drug of the patient or to add medication. If it's important, what this physician treatment is not less the time to establish a diagnosis of hypertension. I'll show you data from my own community. It's a survey in care that was 33 subjects, practically 7 with a previous diagnosis of hypertension, were called family physicians for checking of health. And they have some real, very well established instructions to do if the patient is not controlled, yes. What happened is the mean age of relatively young, 54 years old, 61% were. And we have a structured interview. Then what are the results? Look at here. No previous diagnosis of hypertension, 36,000. At the time of visit, have high blood pressure in practical to 7,000. And according to the they need reschedule it. Well, from these 7,000, more than 2,000 not rescheduled. 32% were not 32% of diet inertia. The other side, those that have the previous diagnosis of hypertension, non-controlled 52%, take action in 2%, but in 57%, the doctors didn't take action increasing medication. Of course, this is important for the fact because a very nice study published several years ago, those subjects, those that are in terms of several parameters, you will see that the impact, evolution of blood pressure control from the initial visit was the worst, doesn't improve like those in follow more and try to put the patients in the treatment and in the dose. What about healthcare? This is much. Each country, even in my country, in the different regions, we have a difference in the health. But we need to one thing that from European Society of Hypertension, during this of the last gala 2013, and we will more in the next lines for the 2000 that are running. Is the question we need to consume, to try to gain touch of the nurses, family physicians, pharmacists, specialists, and put in some way all two actions and speaking in the same words, giving the same recommendation, in order that the patients will be caught and will be followed for the struggle. And I told you of the country, and it's important the availability that in some countries have one medication or no. Fortunately here, as I realize, as I see, you have access for kind of the new medications that are in them now. I analyze it, but one very most important is the background of the mechanism of blood pressure elevation, and then get control in that. Well, if we're using monotherapy, when one patient clinic is not able to know if the patient is have a predominance of the overactive renin-angiotensin, or this is a predominance of sympathetic nervous system in the mechanism of hypertension for sure, or in the total volume content. Then if we touch with one medication that is targeting the system, for sure that we have 33% probabilities of control. And there is another important issue concerning even that in the action of the drug. If you look at this cartoon that you put any of the mechanisms that act in the blood pressure levels. But if you are just an only one, the other ones counterbalance. And at the time of contact are reducing of the counter pressure that getting and doing. And then if you combine two different mechanisms, for sure you are going to have more probabilities to success. And this has been, well, this paper published in the American Journal of Medicine several years ago. In this paper, you will see how whatever the drug that you use, doubling the dose, adding a second drug, the difference in the probability to control blood pressure is practically 4 or 5 times more when you are combining drugs as compared to increasing the dosage. We're speaking about the possibility that increasing the dosage of some of these drugs can increase the rate of urinary effects. Then look at the example. You have a patient, for example, 160 of blood pressure, without treatment. And you have in monotherapy, and this is blue or black, then you will have the probability of approximately 40% of control. If you are using combination therapy, in blood pressure level, you gain approximately 20 to 5%. And this, if we're getting 140, if we are getting that a more value of 130, then the percentage, even gains for the combination the same, but the percentage of the you can get is quite. In this case, okay, then I can more control. But there are other information about what the impact of using one drug or two drugs is the probability to use the risk of stroke. It's high, sure, that's heart disease. But you see that when you are two drugs, you have more abilities to reduce cardiac risk. If we consider that combination three is important one, what lines say to us? Say to us that Joint National Committee or European Society of Hypertension and evidence has continued that in vast majority of hypertensive patients, effective blood pressure control can only be achieved with combination of two antihypertensives. And what the recommended combinations? This diamond in which I try to reflect in solid and green are the recommendations to use. As you will see, recommendation in the use of ARBs, blocker, or ACEs, and also diuretics. Then you have here three that be the base for treatment of hypertension. Then you will see in red after the on target and all trials, it is recommended to control pressure and cardiovascular risk ARBs with AC inhibitors. And then if we go for the blood renin-angiotensin system for calcium channel blockers, you will get here what are the synergies that you will find. The synergies is that in this case, calcium channel blockers that produce vasodilatation in the arterial and produce natriuresis, even that as a reactive, you have an increment of the renin-angiotensin system activity and a less this sympathetic nervous system. In the other side, you have the URB that you produce also vasodilatation, do you facilitate the natriuresis, and then in this case you are controlling the increment of the RAS and this sympathetic nervous system there. And then here, you will see that produce not only arterial but also venous dilatation, that you will see the importance this in order to reduce the side effects of the calcium channel blockers. And then if you put together all the potential mechanisms and the balancing with that, you will see that with ARBs plus calcium channel blocker have a synergistic blood pressure reduction and have complementary clinical benefits that we are going to analyze. And then, as you will see, that calcium channel blockers produce several things that will be controlled for ARBs and the opposite one. Then, as told you before, we are looking for an increment in the reduction in blood pressure. We are looking for in a more protection of cardiovascular risk and target organ damage. But we are also looking for less side effects, because side effects is also an important issue at the time that the patients continues taking the medication or not. And then this is the mechanisms why when you add ARB to the calcium channel blocker, the hydropyridine, in this case will be amlodipine, then you have less edema. In normal conditions, there is a balance in the capillary network in between the arterial and the venous side. When you give one calcium channel blocker alone, what you produce is an arterial vasodilatation, and at the same time that you increases this vasodilatation, that increase the pressure in the capillary network, you have also an overactivity of the renin-angiotensin system that produces constriction in the venular territory, then increases more the pressure and facilitating the fluid leakage and the capillary level. But if you are blocking at the same time, this is more balanced and then you reduce the edema. Sometimes you are not reduced totally the edema, but you are reducing the intensity of the edema and the symptoms that the patient have and for having this edema, mainly in countries when the temperature is really high, the ambiental temperature. But what about more possibilities when you are putting together one ARB with one calcium channel blocker? Then we take losartan. Losartan have been demonstrated during the last 20 years that this is very effective, not only reducing blood pressure, but also reducing cardiovascular events. Remember the LIFE study. Also protecting in the development of, in the progression of diabetic nephropathy in the renal study. In many of the trials had been demonstrated also one effect that reduced the levels of uric acid, and when the uric acid today is a revival in terms to consider what is the potential cardiovascular risk directly impacting in endothelial dysfunction in some other structures. And then what the other one that has been perfectly accepted is the tolerability without side effects, with the same rate of side effects that the placebo. In the other side you have amlodipine. Amlodipine maybe is the most challenged drug in the world. He was the comparative in many trials, and then demonstrated the reduction in cardiovascular risk in the VALUE trial, the reduction in coronary heart disease in the PREVENT and CAMELOT study, the influence reducing risk also in very high-risk patients, hypertensive patients such as the ASCOT, and also impacting reducing the central blood pressure has been demonstrated also in the CAFE sub-study of the ASCOT, and is also used as a drug that was effective, reducing morbidity and mortality in the ALL-HAD study. Then, what they produce both? These are data from a factorial study. This factorial study, what analyzes is the effect in losartan 2 different doses, amlodipine 2 different doses, the combination with 5 milligrams of amlodipine 50 and 100, and the combination with 10. You will see a progressive increment in the probability in reduction. If we are speaking here in diastolic blood pressure, in systolic is even greater. And then this achieve a progressive increment in the rate of control, and as you will see here in this factorial study, that more than 80% of the subjects are controlled and achieved the control that was less than 140/90. But not only this, in another study, you will see the impact in the target organ damage, reduction in left ventricular mass that increases as the dose increases, as expected, reduction in albuminuria, reduction in uricemia, and again, the rates of control that are close to 80% in this study. And then this was the primary outcome, that was the reduction in left ventricular mass, and these were the secondary reduction, that reduction in more than 3 biomarkers. And if you look at this one, it is specifically, you will see that the reduction approximately in 10% in left ventricular mass index, in the posterior wall thickness, and in the interventricular septum. Then it's a trend, not significant, in reduction in the remodeling of the left ventricle. And then, as I told you before, in one study comparing, and as compared to that, the combination with amlodipine with the combination with hydrochlorothiazide, you will see that the differences in uricemia are very clear. Well, if we assume that we can or we need to use combination therapy, that we have the possibility, and one of the most used today, and because they have a very, very important advantages, are the combination of ARB amlodipine. I show you data in losartan amlodipine, how and when to use it. What the guidelines say, and say, whenever possible, use fixed dose or single pill, whatever you prefer to say, combination, because simplification of treatment carries advantages for compliance of treatment. This has been demonstrated in many studies. Then you will see in this very large study with practically 6,000 subjects, you will see that the number of concomitant drugs that the patient have taken, antihypertensive drugs, just in a single pill, the same drugs, or by separate. And you will see here the adherence decreases, as I told you before, according to the number of the drugs that the patients are taking for other comorbidities, so that is really common. But then with a single pill therapy, you will see how it is maintained, the adherence. And then this has been also analyzed in one meta-analysis. And then you will see favor the fixed dose combination in several of the studies that the meta-analysis show to us that there is a beneficial impact, approximately an improvement in 30% of the subjects. And this is translated to the normalization of blood pressure. And another thing that is important, it is translated to less side effects. Why less side effects? Well, because the two compounds are given at the same time. And we are sure that the patients are taking that. But we are not sure if the patients are taking one medication and not the other one, and there are irregularities at the time that take. And then if we have a different dosage or different schedules, for sure the risk to have side effects derived from medication increases. But this is a very interesting one. This was one study that was done in Canada concerning what is the cost for healthcare when we are using combination therapy or when we are using the same drugs but by separate. And you will see that the total reduction is practically a 30%, 25% reduction in the cost due to the less visits, less consumption of other additional drugs, and even that a little bit less hospitalization. Then, in other words, combination therapy is giving us the opportunity, combination therapy in the same pill is giving us the opportunity to get more success in the treatment that we are doing. But finally, there is another thing that the guidelines say, and say the combination of two antihypertensive drugs may offer advantages also for treatment initiation, particularly in patients at high cardiovascular risk, in which early blood pressure control may be desirable. Then the Joint National Committee also recommended that in those subjects that initially need to reduce systolic blood pressure more than 20 millimeters of mercury to achieve the goals, or more than 10 in diastolic, combination therapy from the beginning is advisable. And then what are the evidences that we have? We have one nice study that was published 3 years ago in which a group of patients, very large one, approximately 1,700, then start treatment, once with monotherapy and others with combination therapy, and those that start with monotherapy over the following month get also the necessity to get another second drug. And then you will see what is the impact in all the patients, more than 1,700. You will see here a reduction in cardiovascular risk. But if you look here, these are also the patients not with a very high risk. Here are excluded patients with diabetes, of chronic kidney disease, and still the advantage for that. Then, when we initiate with combination therapy, in several circumstances that we are going to comment, of course, we are gaining time. And I think that there is one thing that is not possible to measure well. But if you have a patient, if you start one antihypertensive treatment, give one drug, and the patient back 4 weeks later, still on control, you are going to increase the dose or even change the drug, the patients become a little bit reluctant and lose a little bit of confidence with you. If you give combination therapy, you are going to get control earlier for sure. And then this is why the European Society Hypertension Guidelines recommended that in patients with high risk, when in patients like the American ones, you need to reduce more than 20 systolic or more than 10 diastolic, you need to start with the combination therapy. This combination therapy, if we don't achieve the control, we can increase the dose of this previous combination or add a third drug that also, if you are giving the third drug in the same single pill, for sure you are maintaining the advantage of getting the benefits of adherence. And then, if we consider another 2 situations in which it's many times necessary combination therapy. Think in your patients with diabetes, think in your patients with obesity, then the majority of them are going to need combination therapy. Because if not, it's not possible to control. Then it needs to be included here too. And then, if we move to the use combination therapy in this, using 2 drugs, like I showed you, losartan and amlodipine. And then you can also follow this side of the scheme, previous combination therapy at full dose, or you decided to go to add a third drug, you have single pill combinations that can give you the benefits that the patients will be more simple therapy, more easy to be adherent, and then the more facilities to start to control as earlier as possible. I will tell you, if a patient didn't receive it before any kind of antihypertensive treatment, or even elderly people, I take precautions mainly to start with a 3-drug combination. I don't recommend to start with 3-drug combination because you never know how the patient is going to respond to the antihypertensive treatment that you are giving. But sometimes, approximately, I will say you that in my country, more than 24% of subjects with hypertension treated, they are given 3 or more drugs to be controlled. Then, this can get benefit. Well, I will show you one real experiment. Let me that I say experiment because it's not experiment. It's what happens in one country, such as Canada, that takes seriously the control of blood pressure. And as you will see here is the trend in that for myocardial infarction, in stroke, and here they start an educational program that every year they release for all the primary care physicians and specialists very clear recommendations, very clear ones. And then you will see how the slope change, slope reducing more. And what was happening at the same time? At the same time was that on starting the program, then increase the prescriptions of all kind of antihypertensive agents. And not only this, increases sharply the prescription of fixed dose combination. This for sure helps to the results that they have obtained. Then, ladies and gentlemen, I would like just to conclude with 3 messages. Of course, blood pressure reduction is the most important goal in hypertension to reduce cardiovascular risk, but the blockade of the renin-angiotensin system offers additional benefit over and beyond the blood pressure lowering effect. The losartan-based treatment has demonstrated not only a significant and organ damage reduction, but also cardiovascular protection, and amlodipine do the same. But, of course, single pill combination of losartan and amlodipine can offer additional benefits in adherence and can be used as a starting treatment in practically, I will say you, approximately 60% of the patients that we are seeing in our clinics. It is that my message, and thank you very much for your attention. That question? Yeah, of course.
Thank you very much, Professor Josep, for that extremely scientific presentation and a very informative lecture on how to manage hypertension. I think the treatment will stay. Indeed, combination therapy is the mainstay to achieve the goal. So perhaps we can entertain 2 or 3 questions from the floor. Any questions? If I may throw the first question, Professor, I noticed, I still believe that the European Society of Hypertension doesn't or totally scrap beta blockers as far as the management of heart failure. But apparently, your slide seems to be, discouraging the use of beta blocker?
That's the issue of beta blockers is a very important issue that our society have the opposite that against the nice guidelines, American ones, because we consider that beta blockers can be useful not only in patients with compelling indications, coronary heart disease or heart failure, but also in some, maybe young people with that have a higher heart rate and have some this overactivity of the sympathetic nervous system can be useful. But even that we maintain in the first line the possibility to use beta blocker is not the most drug used, because then we use and release for these compelling indications young people with this overactivity and nothing more. Of course, we can add for treatment as an antihypertensive treatment if we need to add medications after the 3rd. And then in some patients, beta blockers are used. Even that, the 4th drugs, as I am going to speak later, is not beta blocker. The first one will be one anti-aldosterone drug, spironolactone or that.
Any other questions for Dr. or Professor Josep? A question? Okay, sure.
Can I ask a question in general? Then here in your country, sorry because I don't know well how is the treatment of hypertension here. How many of you are starting antihypertensive treatment with diuretic or beta blockers, let's say that? Beta in monotherapy. Raise hand. Hands rise. Okay, then it's more or less what we are having. And when you are considering that the level of blood pressure to achieve in elderly people, what is your opinion? You are in favor that not go below 150 or go to 140? For the first, raise hand, please. Hand raise.
What number again?
That's in elderly people to reduce below 150 or not?
150 and below for elderly.
Yeah, for elderly people.
Maybe we can,
Yes,
let's
so you
say,
are going down. And no? And the second and the third one, what is the use of the recommendation for home blood pressure measurement here? It is well established? Not really. Then I think that this will be more important in the future because if you see the guidelines that are going to be released shortly by the JNC again, European Society of Hypertension, and has been released also for the Canadian last year, from time to time they are relaying more the blood pressure goals to be considered home blood pressure and not office blood pressure. This came a little bit for the spring trial and then that isn't observed, but I think that this is a very important issue to consider because it's giving us more relevant information as compared to the office blood pressure that can be more, have a higher variability in between visit and visit. And then at that time, using these home blood pressure values, for sure that the goal should be lower and should be below 130 at least. And then. But I think that is irrelevant because the reduction in risk until 130, it's okay, and we are gaining absolute risk reduction, not only relative risk reduction. When we are going 130, things are worse. And then if we consider that we need to arrive to 130, then combination therapy is becoming more and more important in that.
if I may share to you, Professor, the local data that was conducted by one of our directors, Dr. George Season. He did question 3 and he tried to map out as to the most antihypertensive in terms of class, and it was beta blocker. But that was it was conducted a few years back, and for the simple reason that it's in the Philippines you really have to squeeze the amount. It's relatively inexpensive. I guess that's the main reason. But of course, the combination therapy is being widely used here in the Philippines.
Beta blockers, well, have side effects, everybody knows. And at the time to reducing risk, it's very well established that the risk has been produced in coronary heart disease and heart failure, but not protection in stroke. In stroke, calcium channel blockers and ARBs have much more protection than not beta blockers. I think that's important to take.
Thank you, sir. Yes, Dr. Belosilio.
No, I have often wondered why, when we have a hypertensive patient, it seems that nobody bothers to find out what is the pathophysiology involved in the hypertension. It's immediately we treat our patients. That's why, I'm impressed with the infectious disease people. Before we start any antibiotic, they try to find out first what is the organism involved and whether this organism is responsive to medications. But why is it that when we are dealing with hypertension, we think of drugs right away and not basically look first whether it is peripheral resistance, whether it's cardiac output, and if it's cardiac output, whether it's stroke volume or myocardial contractility. Wouldn't it be better? We can very deliberate in our choice of drug.
Yeah, I appreciate the question, and it's a very important question. The fact, I think, is double. First of all, that the prevalence of hypertension is very high, and then imply that the primary care physicians and specialists have many patients with hypertension. And with just only the clinical tools that you have, the majority of people have, it's not possible to be sure which is the situation of the patients as I show you. These three examples, that sympathetic nervous system, renin-angiotensin system, or total volume, total sodium body. Then it's not possible to know. And then for this, the best is you try to assess epidemiologically. For example, that young people that usually have more activity renin-angiotensin system or sympathetic nervous system, that if you have a patient with edema or they have chronic kidney disease or whatever, more volume at the same time that renin-angiotensin system. In other words, it's practically impossible to know the physiopathology. Yeah. This is, sorry that I finished, that this to be considered more when you have a patient that start one treatment and become resistant. I am going to speak this afternoon, I announced that, about resistant hypertension. In resistant hypertension, the second step that I put there is to try to identify what will be the mechanisms. And then you will have several things clinically relevant. And you also can use some devices that are only available at the specialist level, and especially hypertension. For example, that's using impedance to know whether there are more volume or not, and to assess at the same time that impedance, some monitoring, continuous monitoring, and then you will calculate it if there are more vasoconstriction or not. And then, but to think this to apply in hypertension, it is as common, is practically impossible. It's practically impossible to do that. And then this is the reason why you consider a little bit what are the characteristics of the patients, and then you introduce one medication that you have 33% chance to get success.
Doctor, then, we have reached the moon. Why don't we devise means by which we can really determine the pathophysiology existing in our particular hypertensive patient? Well, because in my opinion, the way it is now, management of hypertension, pardon me, is really a guessing game.
Yeah, well, the question is, I told you the difficulties first. And the second one, there is another very important problem with hypertension that, for example, don't exist with hypercholesterolemia. That the parameter, blood pressure, is a parameter that this is really variable. You have a very high variability of blood pressure. Each beat, you have a different blood pressure level. If you are getting office blood pressure, you are getting 24 hours ambulatory, you are getting intraarterial or non-invasive continuous monitoring, you will see that the variability is as much. And then we need to accept some, by convention, what is normal. We know very well for office blood pressure. We know very well that if you treat patients that have more than 140, you are going to reduce risk. But what about, for example, ambulatory blood pressure monitoring? We accept that the normality is during the day 135, but because we did this by regression lines and then. But we don't have information about if treating patients with more than 135 is going to get success or not. In other words, you don't have definition, just only have definition for hypertension in office blood pressure. Even that we have the help of all the other things. But well, it is one of the difficulties, and the pathophysiology is very complex. It's very complex. You need that expertise, you need equipment, and you need time. The three things to get success in that. Thank you.
Thank you. Thank you very much, Professor Josep. And I guess we have to give Professor Josep a round of applause. And thank you for flying, but we'll see you later. And may I call on Mr. Ronnie Ramos from the LRI-THERAPHARMA.
Doctors, good afternoon. On behalf of LRI-THERAPHARMA, thank you for joining us on this very special occasion. As always, this activity is born out of our commitment to you as your trusted partner in caring for the cardiometabolic health of your patients. The success of our partnership comes in the form of better health for our patients, free from the suffering brought about by cardiovascular disease and diabetes. Together, we work towards enabling families to be together longer, enjoying the company of their loved ones. It is a privilege to share in your duty of nurturing and safeguarding the health and well-being of your patients. As your dependable and trusted partners and helpmates, we are always seeking to find new ways to help enhance your practice. We join you in your continuous quest to hone your craft so that patients we serve together can reap the full benefits of our products, our services, our knowledge and expertise. We hope you find the opportunity to be most meaningful as we strengthen our partnership towards better quality healthcare for the Filipinos. Maraming salamat po at mabuhay ang pasyenteng Pilipino.